Okay.
So I've tweaked the topic that was given to me a little bit, because I felt that since we are more into public health space, and I know the dietitians are also into curative, but when it comes to prevention of anemia, I thought the treatment protocols will be left to those who do the actual management. We usually do the diet management and things, but I've tried to cover as much as possible. So we'll look at some introductory parts, and then we'll look at anemia and pregnancy, and then we'll go into the prevention and management. And then we'll look a little about the curative treatment, and that is done. So we all know about anemia. This is just a revision for us. Anemia, we all know, is when you have problems with your blood cells, especially the hemoglobin concentration within them. And anemia can occur if you have too few blood cells, or if you have abnormal blood cells, or if the hemoglobin within the blood cells are not enough, then you could be said to be having anemia. And anemia, hemoglobin concentrations varies depending on your physiological needs, your age, even where you stay, whether you are staying at an elevated place or in the valleys. Also, it depends on sometimes your habits, such as smoking, and then your physiological status. So if you are pregnant, or you are lactating, or you are adolescent, your hemoglobin or your hemoglobin needs will be different. And anemia has so many effects. If somebody becomes anemic, then the person is more likely to get infections and may even die from those infections. Anemia impairs cognitive performance in school-age children and adolescents. And for the workforce, and even for school children, it causes fatigue. So you are not able to give out your best when it comes to learning or when it comes to work. For pregnant women, it affects the pregnancy outcomes, where we are looking at giving birth to preterm babies or low birth weight babies, and generally affects growth and development. So when you have very high levels of anemia within the population, then it is an indicator of the general health of that population. Anemia is very, very, very common. It's very, very common. Globally, anemia is found everywhere, just that the levels may be a little lower in the developed countries, but it affects various age groups, particularly young children, menstruating adolescent girls, and then pregnant and postpartum women. And we'll very soon see how these things plays out, because for children, we know they are growing very fast, and therefore their nutrient requirement is very high. For adolescents, we know that they are also growing very fast. They are at a period where they are growing very fast, and their nutrient requirement is very high. And it's particularly for the girls when they start menstruating and shedding blood every month. And if they are not eating well, and we know adolescent girls don't generally eat well, so we find high levels of anemia there. And then pregnancy and its effect also plays high burden on women in supply of iron and folic acid. When it comes to the figures, children are very, very much affected, as I said. And globally, WHO estimates that 40% of children between 6 and 59 months of age are anemic. And when it comes to pregnant women, globally, 37% is estimated. And for non-pregnant women, 15 to 49 years, it is 30%. And you can see from the chart I have put on the right side of the slide, where it talks about prevalence of anemia among key target populations in Ghana. So if we leave the global level and we come to the Ghanaian setting, you see that for children 6 to 59 months, and this is data from 2017 micronutrient survey. Children 6 to 59 months, we are recording 35.6%, that is close to 36%. Non-pregnant women, anemia is 22%, basically. And then for pregnant women, it's as high as 45%. So anemia is also very, very prevalent in Ghana. And it's one of the top 10 issues that we are dealing with in Ghana. And therefore, for us in the Ghana Health Service, anemia is one of the prioritized things we need to tackle. So we have so many interventions that helps to tackle the issue of anemia among all the target groups, not just for pregnant women. So what causes anemia? Anemia is very complex. I mean, there are so many things that can make somebody become anemic, apart from the target groups that I have mentioned, the age, the physiological status, and others. We also have nutrient deficiencies that happens most of the time among key target group. And in Ghana, most of the anemia we see is iron deficiency anemia, but we also have some nutrient deficiencies that may result in anemia. And so the most common one is, as I've said, is iron deficiency, but we also have folate deficiency, B12 deficiency, and vitamin A deficiencies that are also key contributors when it comes to anemia. And the 2017 micronutrient survey that I just referred to says that it reports that about over 50% of women, non-pregnant women in Ghana, are also folate deficient. So you can see that the issue is quite grave when it comes to nutrient deficiencies. And this happens because generally people don't eat foods that are rich in micronutrients. We have been complaining that our diet is mostly deficient of fruits and vegetables, especially the vegetables, the green leafy vegetables and the legumes and things that will usually give you iron and then the B vitamins. We usually don't take them enough. Then also we have absorption problems that can also result in anemia. So if somebody has repeated malaria or parasitic infections, especially hookworm infections, tuberculosis, HIV, and these affect the absorption of nutrients. Or they also increase someone's need for the iron and folic acid. And so even if you might be taking enough, because your need is high, you may not be satisfying what the body needs. And because of the infections to interact with your absorption, the absorption of the nutrients, and therefore you are not able to get much. Inflammatory or chronic diseases are also part of it, as well as gynecological and obstetric conditions, such as heavy bleeding. So if a girl bleeds very heavily, or a young woman bleeds very heavily and it is not taken care of, that girl might become anemic. Or if there is bleeding after birth or during labor, those are problems that can also result in anemia. Then we have the inherited blood disease disorders, the thalassemias and then the sickle cells. They all contribute to the anemias that we see. And studies have shown that in Ghana, quite some percentage of the anemias we see are contributed by these blood disorders. So this is a very, quite a busy slide, but it gives us some conceptual framework as to how anemia is caused, or the etiology of anemia. So when it comes to anemia, you have the physiological mechanisms That is the first column that we see. And so you have a decreased effective erythrocyte production. And if you are not getting enough nutrients to be able to produce the real red blood cells, then you become anemic. Then we have the hemolysis, so that when the blood cells are breaking down very fast, such as in sickle cell anemia, or in even in malaria. When somebody gets malaria and the blood cells are breaking down, then hemolysis is occurring, and it can cause the decrease in the number of blood cells that you have, and therefore you become anemic. And then definitely blood loss, as I've mentioned, in heavy menstrual bleeding, or even bleeding due to accident or something, can cause anemia. And so when you come to the third column, the one in brown, you see that I've already mentioned that micronutrient deficiencies may result in decreased red blood cells production, and then the infections and all that. So what are the immediate risk factors? Food insecurity, which is very, very key. If you don't have the food, you definitely will not get the nutrients. So food insecurity is very, very important when it comes to dealing with anemia and the etiology of anemia. Then we have when there is repeated childbirth. I mean, so a woman does not recover from the one birth, then she gets pregnant again. That is, the iron stores are not rebuilt. And to think that in Ghana, most of women even go into pregnancy already with low iron stores. And then as soon as she comes out of pregnancy, she's not able to rebuild the iron stores. She gets pregnant again. So access and use of family planning and maternal care also may be an immediate risk factor. And then limited access to health and nutrition services. So if somebody is bleeding heavily and is not getting the gynecological attention that he needs to handle that, or if somebody is pregnant and doesn't go to the health facility to get the IFA and then nutrition counseling and all that, that will be also very, will affect the person. And then water and sanitation, some of these nutrition sensitive things. So we know that when there is no water or sanitation, then people are exposed to infections. And we have already seen that infections may lead to anemia. And all this has underlying risk factors, which are our educational attainment, poverty, conflict, cultural norms, and then the social demographic politics of the country. They all play a role when it comes to anemia etiology. So like I said earlier on, it is a very, very complex, anemia is a very, very complex condition, and therefore it is not, the its control and its management is not solely resting in health. It has so many components, and therefore it needs to be handled intersectorally or collaboratively, because you need, when you're talking about water and sanitation, it doesn't rest in the Ghana Health Service or in health. It rests in another agency or another ministry. And therefore we need to collaborate to work when we need to talk about anemia or prevent anemia or control anemia. So now let's look at anemia in pregnancy. Anemia in pregnancy. I mean, when somebody becomes pregnant, we know that there's a fetus growing in the person, and therefore the fetus is growing. And the fetus also has a placenta that is attached to the mother's body for exchange of nutrients and fluids that is also growing. And then there's expansion of the blood volume. So there's serum expansion, and all this lead to increased demand in nutrients, because the child demands nutrients. The placenta also takes some of the nutrients. The sheer volume of the blood also makes the concentration of hemoglobin less, and therefore it looks like the person is anemic because the blood volume is increased and the blood cells are less, the red blood cells or the hemoglobin is less. And then I also mentioned earlier on that in Ghana, most, and not just in Ghana, in most developing countries, women start pregnancy with depleted iron stores because most of the time the pregnancy mostly is not planned. And so women don't prepare their body for pregnancy. And therefore the iron stores is already low before the person becomes pregnant. So if you enter into pregnancy with low iron stores and at the same time your need for iron has become very high, then it's likely that you will be anemic during your pregnancy. So in pregnancy, anemia is defined as an HB level below 11.0 grams per deciliter. And anemia in pregnancy is considered mild if the HB level falls between 10 and 10.9 grams per deciliter. If it is between 7 and 9.9, it is moderate anemia. But if it falls below 7 grams per deciliter, then it is classified as severe anemia. Anemia also can be classified according to the etiology of the anemia. So we can classify anemia as being physiological. And some of the pregnancy we see, the anemia we see in pregnancy are physiological. And so I have explained already that during pregnancy, the plasma volume increases, and it can increase as much as 50% throughout the pregnancy period. And that comes to 1,500 mils by the time the pregnancy is at term. And most of this is found within the second and third trimester. So this happens mostly between the second and the third trimester. And thereafter, when it gets to the fourth trimester, the blood volume has stabilized, and so therefore there's little change over there. Even though the blood cells also increases, the number of blood cells increases because the body produces more blood cells to compensate. The amount of volume expansion compared to the amount of blood cells that is increment, it's low. So therefore there's a relative hemodilution, which produces the fall in hemoglobin concentration that we've seen. And therefore it presents the picture of anemia, because if there's hemodilution and then the concentration is false, then definitely you are not going to get the 11 grams per deciliter that we mentioned about, and this will result in anemia. Then we have the pathological anemias where iron deficiency. This is where we are having deficiency. So iron deficiency, folic acid deficiency, vitamin B12 deficiencies, all can result in various forms of anemia that we see. Then the hemorrhagic anemias following acute bleeding. So when there's heavy bleeding, maybe as part of pregnancy, during the early part of pregnancy, or even anytime within the pregnancy, it could be bleeding due to the pregnancy, it can be bleeding due to an accident. It's all hemorrhagic, and therefore it can cause anemia. And then also when there's chronic blood loss through infection like hookworm infection, or a bleeding pile somewhere which is not attended to, this can also cause anemia. Then we have the hemolytic anemia. This is where the blood cells are breaking down very fast. And sickle cell, as I've said, can cause that. And then malaria, severe malaria. So when you have severe malaria and your blood cells, the parasites are breaking the blood cells, then you could also result in anemia that is referred to as hemolytic anemia. There are also the bone marrow insufficiencies, and then the hemoglobinopathies that we'll talk about later. In pregnancy, most of the anemia we see are nutrient deficiencies. So nutritional deficiencies of iron, folate, and vitamin B12 due to low intake or poor absorption may result in anemia. Apart from the physiological anemia, that is the hemodilution, if a woman does not also eat well, then it makes anemia worse. But even though hemodilution takes place during pregnancy, if a woman is already iron, not iron deficient, he has good iron stores and is eating well, then that pregnant woman may not necessarily become anemic. So what we are saying is that is because mostly people go into pregnancy not prepared and therefore have low iron stores. And then also generally people don't eat well, especially during the first trimester when we have all these problems of nausea, of not feeling good, and people don't really eat well, and therefore anemia can't easily set in. And then we also have economic and sociocultural factors, such as religious factors, food taboos, and then so there's it, and there are places where even a pregnant woman is not supposed to wear sandals. So if you're a pregnant woman and you're supposed to walk barefooted, then you are likely to get hookworm infections and other helminth infections that can cause you to become anemic. Or if you are from a cultural background or a cultural setting that you are not supposed to eat some foods that may be iron rich or nutrient rich, and there is no other replacement or alternative. Either you don't know that there's an alternative or you don't have access to that alternative, then you may become anemic. And then we also are very well aware of some religious and taboos that significantly contribute to the fact that women desist from eating some particular nutritious food when they are anemic. Parasitic infections also occur in pregnant women. And then anemia in pregnancy is more likely to occur when there are multiple pregnancies. So if a person is pregnant with twins, then you know that the body is going to demand more of the nutrients, because then the body has to, the mother has to provide nutrients to for two fetuses developing, and it may be two placentas. So that's also one thing to contend with. So in anemia in pregnancy, those who are likely to become anemic is those who are with multiple pregnancy. I've said it, those not consuming enough iron. And then if the pregnancies are too closely spaced, so back to back, she comes from another pregnancy, immediately goes into pregnancy again, the body doesn't get time to recover, and therefore the iron stores are low. Then if there's a lady who experiences heavy menstrual flow before she became pregnant, it's likely. And then those who vomit a lot, and definitely a teenage mother may be more likely to become anemic, because she herself, her body needs more of the nutrients, and now she has another fetus to cater for. So her needs becomes even more and may become anemic. So these are things we already know, signs and symptoms of anemia in pregnancy: irritability, depression, breathlessness, poor memory, muscle aches, palpitation, weakness. And then what we usually look for, and that one everybody can look for, is the pallor. So, but what we have to know is that sometimes before somebody can show pallor, then the person may be severely anemic. So if the palms becomes very white for you to see, then the person may be severely anemic. When you get glossitis, and then that is inflammation of the tongue, and then stomatitis, that is the cracking of the lips and all that, then you will know that there are other nutrients involved. So the B vitamins usually will give you glossitis and stomatitis. So if somebody gets anemia and is having glossitis, stomatitis, then know that there are other nutrients that are implicated in that anemia. Anorexia may also happen when anemia is present in the pregnant woman. So what are the effects? For the woman, anemia may result in repeated infections, and therefore, because there's reduced resistance to infections, anemia, iron plays a role in immune status building. So if you don't have enough iron, then your immune status will go down, and then you may be having repeated infections. Then if you are anemic already and you go for delivery and you bleed a bit, your situation will become very serious because you already are anemic. Then for an anemic pregnant woman, there's a predisposition of getting pregnancy-induced hypertension or preterm labor. There's always fatigue, and definitely anemia is a threat to the pregnant woman, because if you are pregnant and anemic, then there's a potential threat to your life, to the life of the pregnant woman. And the odds are that if you are severely anemic, then you are twice as likely to die from childbirth as compared to somebody who doesn't have severe anemia. So it is a very serious situation, and most of the complications that is seen around childbirth and maternal mortality are hemorrhaging, so that you know that bleeding, usually when you don't have enough blood, that's when you bleed, because the things that should make the blood clot are usually not there. So it's very, very important. And then for the child or for the fetus or the baby, there's growth retardation, and the baby is likely to be born either premature or with low birth weight. And then because the mother is anemic, so the child is born with very limited iron stores, and therefore the child usually may become anemic before the usual 6 months when the iron stores is supposed to have been depleted. There's increased rates of perinatal morbidity and mortality. So this is the general introduction about anemia. It's just a refresher about what anemia is and how it complicates the situation during pregnancy. Now let's look at the prevention and management. So I'm looking at prevention first. Actually, improving the consumption of micronutrients, iron and vitamin B12, folate, riboflavin, vitamin A will help to also improve your hemoglobin status and therefore improve your anemia status. And as part of improving consumption of micronutrients, we advise that people eat a lot of fruits and vegetables, including protein, so that they'll get the nutrients that they need. But fortified foods are also recommended, or supplementation are also recommended. And what I'm saying right now is just for the general public at the individual level. So food fortification, to prevent anemia amongst the population, apart from promoting the consumption of diversified foods that are rich in micronutrients, we may also want to recommend fortified foods. And we know that Ghana, we have wheat flour has been fortified with a cocktail of nutrients, including folic acid, zinc, iron, vitamin B6, vitamin B12, just for us to improve our anemia status. We can also encourage supplementation. So girls and young women who are not eating well and can always do supplementation. So iron and folic acid is a very good supplement that can be taken by women in reproductive age to prevent anemia. And that is why we have started a gifts program where we are giving iron supplement to girls so that they will not become anemia. And we are also encouraging women who are not pregnant, non-pregnant women, to just go and buy supplements and take, whilst we continue to preach the very, very rich, diversified foods. Preventing malaria is also one very, very important prevention method. So sleeping in separate bed nets or using chemo prevention methods is very, very important. Then apart from making sure you prevent malaria, we have to also make sure that when somebody gets malaria, the person gets immediate treatment so that the blood cells will not be broken down. So transmitted helminths and schistosomiasis are also very, very important infections we have to look at. And then birth spacing for women. So we need to, if we want to control anemia amongst WIFA or in the population, we also have to be promoting family planning and birth spacing specifically, so that people can have time to recover and build their nutrient stores before they go into pregnancy again. They're managing the heavy bleedings and postpartum hemorrhages and things is very, very important. Delaying umbilical cord clamping after childbirth has been seen to also help, especially for a transfer of iron from the mother to the child after childbirth. And then managing inherited blood disorders such as sickle cell and thalassemias. And then we all need to raise public awareness about anemia. So we need to raise public awareness. We need to talk to mothers how to prevent malaria and how to be conscious about when they want to get pregnant so that they can prepare their body. So we need to prevent anemia in the general population. If we promote anemia prevention activities, then we know that everybody in the population, including children, men, women, will all be and will have very good iron status, and therefore anemia, when they become pregnant, anemia will not become an issue. But when a woman becomes pregnant, and then we'll have to take specific measures to prevent anemia in that pregnant woman. And so the first thing is to make sure that we check the HB levels. And so in our Ghana Safe Motherhood Protocol, that also deals with anemia and pregnancy. Anemia is checked on the first day that a woman reports pregnant. And now we are advocating that women should report as early as possible. Gone are the days when people say they want to wait until after the first trimester, or maybe even in the third trimester before they come, because they don't want the witches to see that they are pregnant. Now, it is not the witches that will kill your child. If you don't come early for to receive services, that is what may kill you or your child. So we are promoting early and registering at antenatal. And then as soon as the person comes on the first visit, there should be HB taken. So in Ghana, all pregnant women are supposed to have 3 hemoglobin measures, at least 3, actually, as 3. If a woman is found to be anemic, he may take more than 3 because you want to monitor the HB status. But every woman is supposed to take at 3. Every pregnant woman is supposed to take 3 HB measurements before the end of the pregnancy. And it is advised that the first should be taken at booking. And as I said earlier, we are expecting that booking starts as early as possible within the first trimester. Within the first trimester, the woman should book. So when the HB is taken within the first trimester, then in the 28th week, another HB is taken. And then in the 36 weeks, another HB is taken, so that we know how to manage the anemia. It is very, very important to take the HB at 36 weeks, because then the woman is nearing term. And if the woman is anemic at that time, then if there should be very drastic measures to reverse the anemia, and if need be, even get blood transfusion before the give birth, or make the woman is prepared to make sure that blood is available during the time of childbirth, so that should she need blood transfusion, it is quickly given. Then so I've said that we need to determine the hemoglobin levels, and then listen. And then also, every pregnant woman in Ghana is supposed to, whether you are anemic or not, you are supposed to take IFA every day for at least 90 days throughout your pregnancy. But it is important to take even as long as 180 days before the end of the pregnancy. And this, we are supposed to take a 60 milligram of elemental iron and then 0.5 milligrams of folate as part of focused antenatal care package. So anytime you come to antenatal care, you are supposed to make sure that you get your iron and folic acid supplementation. Now we are also, and the evidence is showing that multiple mineral and vitamin supplements are also very, very effective. So what we call the MMS are also very, very important when it comes to taking care of the pregnant woman to prevent anemia. So this is prevention. When the woman is found to be anemic, then there is a treatment, and that is not just the 1 tablet per day. That is another treatment altogether. But this is the preventive dosage, which is 1 tablet of iron tablet and 1 tablet of folate per day, and it's a 60, at least it must contain 60 milligram of iron and 0.5 milligrams of folate. Then we also have to make sure that we prevent malaria, because malaria is one of the infections that creates a lot of blood loss and then anemia. So malaria in pregnancy is prevented, and that is why the National Malaria Control Program, now it is National Malaria Elimination Program, recommends at least 3 doses of SP for intermittent preventive treatment during pregnancy, so that the woman is protected from malaria. And then also, they also treat for helminths and all that, but that one, it is not general. I mean, if a pregnant woman is found to have worms or some intestinal and so soil-transmitted worm infections, then that woman is also treated with the appropriate dewormer to prevent that. But when it comes to the curative treatment, like I said, every woman who is found to be has HB below 7.5, that is found to be severely anemic or close to becoming severely anemic, ideally must be hospitalized and then be treated. So that is one. If a woman is, especially if the woman is near term and is found to have HB low 7.5, that is getting to severe anemia, then there must be hospitalization and treatment. Sometimes it may be important to do antibiotic treatment, because if there's malaria that may be causing the anemia, or if there's any other infection that may be complicating the anemia, it has to be treated. But there are 3 modes of treatment of malaria, and I didn't put any dosages here because treatment of anemia in pregnancy is done by the the doctor or the obs-and-gynae specialist. So we just need to know what needs to be done. So either the pregnant woman will be given oral iron tablets or blood tonics, or they will be given injection, some injection that contains some iron, or there will be blood transfusion. And whether the anemia will be treated orally or parenterally or by blood transfusion depends on the duration of the pregnancy. As I said earlier on, if it is near term, the more drastic measure must be taken. And associate complicating factor. So if for instance, if the pregnant woman is a sickle cell patient, then the treatment might be different from somebody who is not a sickle cell patient. So it depends on the duration of the pregnancy, that is the gestation, and then the associated complicating factor. So when it comes to oral, usually we use ferrous fumarate, ferrous gluconate, or ferrous succinate. And then I also talk about the MMS, so the multimineral or multi-mineral supplements. And that one contains iron, folic acid, plus a whole lot cocktail of other micronutrients. And the evidence is showing that they are very effective because iron absorption also depends on other factors, and the nutrient-nutrient interreactions also play a role here. Then when it comes to parenteral treatment, it's given when there are contraindications for oral therapy. So for instance, some people, when they take iron tablets, they vomit a lot. Some say they don't want the scent. Some, it gives them gastrointestinal disturbances. So then, the doctor will decide to give an injection. Yes. Or if the patient is somebody who will not take the medicine, for tablets, it is given for you to take. If the patient will not cooperate in taking, then the doctor might think about giving parenteral and this thing. And then sometimes if the person is seen in the first 8 to 10 weeks and the person has severe anemia, so the person is seen in the first trimester, and even in the first trimester, the person already has severe anemia, you may want to bring back and treat the anemia parenterally, because that one may be a little faster. Okay. Then when it comes to blood transfusion, this one is usually done when there is loss of blood due to bleeding, PPH. So if the woman has delivered and is bleeding, then you want to prevent anemia. At the same time, you want to replace any blood loss. So you have to quickly give blood transfusion. And then patients with severe anemia seen later in pregnancy. So if the person is seen later in pregnancy with severe anemia, then blood transfusion may be considered. And then for anemias that are not responding to either oral treatment or parenteral treatment, despite giving the correct dose, despite making sure that the person takes the hematinics, if still the anemia is not resolving, then we might think about giving blood transfusion. Now I want to talk about the hemoglobinopathies, because they create a lot of problems in pregnancy. Yes, and there are some of the anemias we see are due to hemoglobinopathies, and usually their outcomes are not too good when it comes to people with hemoglobinopathies if they are not handled very well. So these are inherited blood conditions where the hemoglobin is abnormal. So you can have, and it's usually because of defective genes. So it leads to the formation of abnormal hemoglobin. So if the gene the defective gene results in impaired globin synthesis, then you have thalassemia syndrome. But if the defective gene results in structural abnormality of the hemoglobin or the globin part of the hemoglobin, then you have what we call sickle cell anemia. And in fact, their effect on the pregnancy is that it increased the abortion, incidence of abortion and prematurity within the woman. And then there's high perinatal mortality. So there's a lot of fetal losses in these people with hemoglobinopathies. So if the person has thalassemia syndrome or a sickle cell, and depending on the severity also, if the person is just a sickle cell trait, then the person would not have any issues. But if the person has hetero, or and both cells are sickle, like SSSC, then there's issues. Then so there's increased prematurity, then high prenatal prognosis, then incidence of preeclampsia, eclampsia, and infections, and then increased maternal mortality due to infections, cardiovascular accidents, and sickle cell crisis. So somebody can be, when they are pregnant, they usually get a lot of sickle cell crisis and all that. So for the management of the sickle cell and then the thalassemias, the first thing to do is to make sure that there's preconception counseling, so that the person can make informed decision whether she wants to even get pregnant in the first place. And if she doesn't want to get pregnant, then there should be contraception that is available for that person to take. And we are not doing that, but they also, because of their condition, there are so many of the contraceptions, some of the contraceptions they cannot use. So they have to know which contraception is good for them. But if they should become pregnant, then during pregnancy, their folic acid, especially for the sickle cell, folic acid should be increased. When they are not pregnant, they take folic acid, I think 400 micrograms a day. When they are pregnant, they have to increase the folic acid to 5 milligrams per day. And then iron supplements, they are not usually given iron supplements, but when they are pregnant, iron supplements may be given depending on the serum ferritin results. And therefore, when they are pregnant, they need special care. They need to do all this, their serum ferritin, to see how low the ferritin is. If the ferritin is very low, then they may have to do iron supplementation. And then for the gynecologists or the obs and gynae specialists may also require that they receive frequent blood transfusion, because their blood cells are breaking down very, very fast, and because of the physiology, because just like any other pregnant woman, they also have the hemodilution and all that we talk about. Therefore, their need for iron will be high, but they cannot take iron supplements. So most usually, if need be, they'll have to get regular blood transfusion. And then they are given prophylactic antibiotic therapy, so that they are not, they don't get infections, because infections can make the situation worse. They have to prevent prolonged labor, because that can trigger a crisis. And then the cesarean section may be advised. But then, even if cesarean section is advised, it has to be managed very, very well. It has to be managed very, very well. So then we come to the diet treatment. And this, I'm talking to mostly nutrition officers, so I'm not going to go so much into this. But we know that to prevent anemia, the pregnant woman needs to eat very well. So foods rich in iron should be accompany every meal. So every meal should have something that is rich in iron. And here the aim is to get 3 servings of iron-rich foods every day. And so some of the foods, like we know, liver, fish, seafood, meat, and all kinds of eggs and all that, they are all rich in this thing. But most especially, we should also encourage the consumption of animal foods. It is very, very important. That is why now we need to stress on all the food groups, including the animal foods. That's why we keep on stressing on the 4-star diet, because if you just say 3 food groups, then he takes legumes all the time and leaves the animal products. Remember that for vitamin B12, you need to get animal products. Otherwise, then you have to supplement. So animal products is very, very important when it comes to anemia prevention. Of course, the green leafy vegetables, the groundnut, the legumes, they are all very, very important. But we also have to stress on the need to include vitamin C rich foods in the food they eat, because we know that for the plant-based foods, the iron is not too much bioavailable, and therefore you need vitamin C to improve the absorption of the iron. And also we have to make sure that we include education on some of the things that hinder iron absorption, like the teas, the coffees, and then some of those things. So drinking them with meals will have to be avoided. And for a pregnant woman, drinking too much coffee or teas is not so much recommended. Yes. So that is this thing. And so we have our 4-star diet. I haven't included the staples here, but the staples are also very important because they also have to eat to get enough energy. Then also nutrition counseling is very, very important. So we need to integrate nutrition counseling in the antenatal care for the pregnant woman and also for postnatal care. And the focus is for us to get the pregnant woman to eat a healthy diet, so that number one, there will be optimal weight gain. There will be optimal weight gain during the pregnancy. And one of the reasons why we are encouraging that people should come to antenatal in the first trimester is that at the first trimester, we are able to take their pre-pregnancy BMI, or what we call the BMI actually. We are able to take the BMI. And once we take the BMI, we are able to calculate how much weight the person needs to gain throughout the pregnancy. And therefore you can monitor. So it's very important. The pregnant woman doesn't have to gain too much weight, but he has to gain enough weight so that he can be healthy. Yes. And one of the reasons why we need to do nutrition counseling is to encourage them and support them to take their supplement, also their IFA or their multi-mineral supplements. We have to encourage them to take it. So when we are doing nutrition counseling, we are doing basically 3 things. We are assessing the situation, we are analyzing the situation, and we are taking action to improve the situation. So when you do assess, you are asking the woman questions to be able to evaluate and estimate the nature of the situation, whether she's eating well, what types of food she's eating, whether she's meeting all the nutrients that she needs, or she's getting all the groups, whether there is variety, whether she's eating frequently enough. You are asking questions to be able to get an understanding of the woman's situation. And then you do the analysis. So after you have gathered the information, you think about the information that the woman has given you, and you compare with what are the recommended practices. So the woman is supposed to eat maybe 3 times a day plus 1 extra snack. Is she getting that? So if she's getting that, then she's eating frequently enough. Then what is she eating? Is she getting all the nutrient that she needs to get? Is she getting some animal foods? Is she getting some fruits and vegetables? Is she getting the staples? You consider all that. And so then after you have compared what the woman told you with what is supposed to be, you are able to make come out with what the difficulties are. And then you prioritize them, and then you take action. Action is putting in place a plan. So you discuss with the woman how you are going to improve her nutrition. And so if you look in the maternal and child health record book that we use now, there is a table for nutrition counseling and for the pregnant woman, and it is found at the antenatal section. And so if you see any chart in the book with this color, it means that it is antenatal. So how to fill this chart? I'm taking my time to take you through the chart because when we go on monitoring, most people say they don't even know about the chart. They don't know how to fill this chart. So the chart has on the left column, the first column, top, you have the date of counseling. So you write 3. And you can see that there are 3 columns, and each column is for 1 counseling session. So it is recommended that throughout the pregnancy, the woman should at least have 3 counseling sessions. If you counsel more than 3 times, there are pages in the book where you can open and write the subsequent ones. So when you are counseling, you just write the date, and then you come to hemoglobin. So you have assessment on the very first column. You have the assessment, and then you have hemoglobin. So you assess. What is the HB saying? Is the HB normal? Is it moderate anemia? That is between 7 and here they've written 11, but it actually should be 9.8, 10.9. Okay, so it's between 7 and 11, yes. And then is severe anemia, it is less than 7 grams per deciliter. You tick so that it will inform you when you are taking your action. So if the person is severely or moderately or normal, you say it. Then you come and look at the feeding history. So you ask the pregnant woman about the food she eats. And like we do our normal recall. So you ask about the food she eats. And as you are talking with her, you are taking notes. So in the end, you have to determine whether the meal frequency is adequate and whether the variety is adequate. So you are asking how many times she's eating in a day, and then you are determining whether it's adequate. You are looking at the variety. Is she having all the 4-star diet or all the nutrient that she required? If she's having all, then she's having variety. If she's not having a particular, maybe she's not taking animal foods, then there is a gap. She's not taking animal food. So you have to put it here that maybe she's not getting animal food, or if the varieties and she's eating a varied food, fine. So whatever you find, you write here. Then your analysis. So the analysis, after you have looked at the HB and then this thing, then you look at what's, in fact, you have to look at food and hygiene practices too. And here under the assessment, you also have to ask about the intake of supplements here under the assessment. Then you do your analysis and then you record the actual gaps. So if here she's eating only twice a day, maybe you write that here, you write eat twice a day. But when you come to the analysis, you need that there's a gap, it needs to eat 1 more meal or needs to increase the distance or not eating frequently enough. You have to write what the actual gap is. If she's not eating a variety of food, you write not eating a variety of food, and then you indicate which of the food groups she is not eating. Then the recommended action. So you discuss with her. She's not eating animal protein. Why is she not eating animal protein? You discuss with her. Maybe she says she cannot tolerate fish. She cannot tolerate meat. So what can she tolerate? Can she tolerate eggs? Even the fish, is it all fish that she cannot tolerate? Can she tolerate dry fish? Can she tolerate smoked meat? So you talk to her, and which of them can she get to buy? So then you put down the recommended action, the actions that you have agreed with the mother that when she goes home, she will go and do. Then you write your remarks. If she says she's not taking her IFA, maybe you write your remarks and then maybe encourage to take her IFA or whatever you put it here. So that is the nutrition counseling table. Okay, and so these are the anemia at the population level. This is the anemia prevention interventions that we are doing. We are promoting dietary diversification, and so increased production of and consumption of iron-rich, vitamin A-rich, and vitamin C-rich foods. So we are promoting that. And of late, we have come back out with the food-based dietary guidelines. So these are also guiding us to be able to promote the diversified foods, including the iron-rich and nutrient-rich foods. Then we are strengthening the iron and folic acid supplementation for pregnant women and also for adolescent girls. We are strengthening the iron and folic acid supplementation programs for pregnant women and adolescent girls. We are collaborating with other agencies within the Ministry of Health and out of the Ministry of Health to make sure that control of infections, including wash facilities and all that, are available so that we'll reduce infection and infestations. And then we have food fortification that looks at making sure that processed foods are fortified with minerals so that they can be healthy for the pregnant woman. So in summary, anemia in pregnancy is commonly, and it must be screened as soon as possible. We see the woman and carry the woman to eat foods rich in iron and other micronutrients. And then we need to support the woman through counseling their families throughout the pregnancy so that the outcomes for the baby. Thank you very much.
Wow. Thank you so much, so much, Auntie Vero. This was a very insightful, highly educated session and presentation. Your high level of expertise on the topic really showed, and we are so thankful. Thank you so much. Dear audience, it's time for your questions. Let me firstly go to our chat box. Auntie Vero, you have the first question.
Okay.
Please, yes, I'll read from the chat. Please forgive me if I don't address anyone asking the question by your titles. I apologize. So I'll call you Mr. or Madam. So Mr. Ama Ayi said, beautiful presentation, Auntie Vero. However, I am worried when you suggest intake of liver as part of the ASF for mitigating anemia in pregnancy. He's saying the high content of vitamin A is contraindicated, so I think it should be excluded. Auntie Vero, your take on this?
Yes, I've heard that. Okay. Yes, I think Prof. Ama is right. So I think because of the high content of vitamin A, and because too much of vitamin A is contraindicated, yes. So we may be very cautious about recommending the liver. Thank you, Prof, for that. Okay.
Thank you so much for your question. Please, you can unmute yourself and kindly ask your question if you have any question. Mr. Lukman, you see, has raised his hand. Kindly unmute yourself. Ask your question, please.
Okay, good evening.
Good evening.
Auntie, thank you very much for that insightful presentation. So mine is just clarification I want to seek regarding the classification of anemia. Earlier in your presentation, I saw 7.5 milligrams, 7.5 grams per deciliter, and that one was referring to, below that was referring to severe anemia. But in the MCHRB on page 9, the table that you presented, I saw less than 7 grams per deciliter. So I want to know which one is it. Then regarding the treatment for the ways of preventing anemia, there were these supplements you mentioned, that is folic acid and also anemia, and the composition specifically for the folic acid. I heard you mention 0.5 milligrams. In other words, that's 500 micrograms. And so if you look at the supplements in the market, most of them are either 1 mg, 1 milligram, or 1,000 microgram, or you will find 0.4. And I think the supplement that we were using earlier was having a composition of 60 milligrams iron and 0.4 milligrams of folic acid. So I don't know, is there a review in the cutoffs, if any? Then finally, some of the officers, some of us are actually working in deprived areas, villages to be specific. And so if a woman comes to us and then you assess the HB and you realize that it is less than 7 milligrams per 7 grams per deciliter, referring them for blood transfusion. I think that is the protocol. Referring them for blood transfusion sometimes may be a bit hectic for some of them. So some of them will even ask you, is there any other option? And before some of us were posted, they were using some things, some hematinics like Totima and the rest. So they prefer that one. Is it advisable to give that instead, or we should just follow the protocol? Thank you.
Thank you very much. Your question is quite loaded. For about the classification, I think on my initial slide, I can't see my slide again. I don't know what is happening. I can't see. Can you see my presentation?
No, actually, I think you ended it. Do you want to reshare?
Okay, let me reshare.
You can reshare.
Okay. Can you see?
They're not coming.
Yes, but you can reference the slide you are talking about, if that will be okay for you.
Unless I don't know, I can't
shop online.
Let me see.
The mountain was like 3,000.
Okay, so let me see.
Please, it's in. It's sharing now.
Yes, I have. So let me see.
No, just the total. This is SO.
So if you look here, if you look on this chart, severe anemia is less than 7.0 grams. Can you see that, Raman?
Just like the anti.
Yes, I can see that.
Yes, okay. So the 7.5 that I'm referring to, the 7.5 is when it came to the curative treatment. And the curative treatment, it said hospitalization if HB is below, you see that here they didn't write severe anemia. They said if it's below 7.5, and I was saying that if it is becoming severe, even though now it is not severe, 7.5 is very close to severe. Yeah, so if you get somebody becoming 7.5, then there should be hospitalization. And the hospitalization doesn't necessarily mean that there will be blood transfusion. I said hospitalization for the treatment of the anemia. And I was saying that in the treatment of anemia, there are 3 treatment options. There could be oral, there could be parenteral, and there can be blood transfusion.
Yes.
Are you following?
Yes, ma'am.
And so, and whether whatever is chosen will depend on the duration of the pregnancy and the complications. You remember I said that?
Yes, I do.
Okay, yes. So that answers your first question. Yes.
Okay.
So the second one,
The folic acid.
The folic acid, actually, what I gave, the 0.5 milligrams is the one in the Safe Motherhood protocol. But we have a lot of different formulations on the market. And you usually don't rather get the 0.5 milligram. Normally what they get is the 1 gram, right?
Yes, the 1 milligram.
The 1
milligram, which is milligram, and it is 1,000
yes,
microgram.
1 milligram, yes. So what they get is the 1 milligram, yes, actually. So normally that is what they take, the 1 milligram. Excuse me, please.
Yeah.
Excuse me, let me take this call. Hello, Eugene. Eugene, sorry, thank you. Sorry about that. Okay, so the formulation is that, but so that is it. So now there is talks to get to streamline what is on the market, but usually what is on the market is different from what is in the protocol, and so they buy what is available on the market.
Okay.
Yes. Okay.
Thank you so much, Auntie Vero, and Lukman, thank you for your question as well.
And I want to address the other issue about the 400 milligrams. The 400 milligrams, that the one with the 400 milligrams is what we use for the GIFT program.
Okay.
And and that one, the GIFT program for the adolescent girls, it is supposed to be 60 milligram iron and 400 micrograms. So that one is okay.
Okay.
And then when it comes to those of you living in the deprived areas, in fact, this is an issue. If the woman is near term and the HB is very, very low, you might want to encourage her to go to hospital for assessment, and then if there's any special treatment that will be given. However, it's good not to keep the woman, because for a person who is near term and the HB is very low, that person, when it comes to delivery, may have complications. And therefore, keeping the person at that level is not too good. But for the meantime that she hasn't gone to the hospital, you can keep on giving the hematinics. But you need to encourage them to go and see their obs and gynae specialist or the doctor.
Thank you.
Thank you very much.
Thank you so much.
Madam Dede, please, before you move on to another person, I just need clarification on this one also. Regarding my boss, Prof. Ayi's question, that is the vitamin E. I read somewhere vitamin E is also one of the nutrients that enhance the absorption of iron. So I don't know. I need a little education around what he meant by contraindicator. Thank you.
Okay, thank you so much. Auntie Vero, is that coming to you or is going to Prof?
Oh, I can handle it. Prof can also chip in. Yes, okay. But what we are saying that vitamin A is good, and it enhances the absorption of it. It helps in blood formation, the absorption of iron and all that. But then the vitamin A in liver is very high. You remember we used to give vitamin A supplementation for pregnant women and women who have delivered, but it was stopped because it was realized that too much vitamin A during pregnancy is not good. It may affect the fetus. And therefore the vitamin A content of liver is very high. And so we will not want to encourage women to eat too much liver. In any case, if they eat their usual healthy diet that also contains vitamin A, then they will get some vitamin A, but that will not be too much. maybe Prof can add on.
Yes, Auntie Vero, thank you so much. I saw Prof's hand up, but I'll quickly go to some messages in the chat and then quickly get to Prof as well. And once again, I apologize if I'm not able to address by your right title. So Madam Pearl Ketcher is saying that, thank you so much, Auntie Vero. Very power-packed. I am happy you mentioned MMS as well. And then we have a question coming from the Canada-Ghana Nutrition Center. I think that's Madam Mavis. She's asking, do cost, okay, I think she meant due. Yeah, due to cost of food, I have noticed an increase among pregnant women, maybe she's saying wele, okay, as a protein option. What is your take on this? And then she says, thanks for the wonderful presentation.
Please, what is the protein option?
Wele. She's
Wele,
asking, yeah, Wele.
okay.
Due to I think maybe financial challenges.
Yes.
She's noticed that pregnant women are resorting to taking Wele as a protein option. So she wants you to do that, please.
Okay. For Wele, I would not advise as a protein option at all. Wele doesn't contain much protein. It is not a protein option. I mean, if they have money to buy Wele, because Wele is also not cheap. Now I know Wele is not cheap. For me, buying even beans or if they cannot provide meat, and the only meat they can provide is Wele, I would rather they use it to buy soya beans, which is a very good source of protein, rather than buying Wele. Because Wele is not for me, it's not healthy, apart from the fact that it doesn't contain much nutrients. It's the way it is treated, the way they bend with the car tie and all that makes it a very, very unsafe food. That is my take.
Thank you so much, Auntie Vero. We have another question in the chat. It's coming from Madam Christiana Insia Asamoah. She's asking, are midwives empowered adequately to complete, that is, fill the nutrition counseling section of the maternal record book? Auntie Vero.
Yes, I've heard you. In fact, we have trained as many midwives as we have trained nutrition officers and community health nurses. In all our training of the maternal and child health record book, we try as much as possible to add midwives. The issue is about getting time to fill the forms and thinking that it is not their part of their work. I mean, because it is called nutrition counseling tables, or because it is a nutrition counseling, some midwives feel that it is the nutrition officer that should do it. But if there's focus antenatal, then the midwife should be able to do it. So we try as much as possible to give the midwives nutrition counseling skills. We invite them to our trainings so that they will understand. My advice is that if you are a nutrition officer and you are working in a facility where the midwives find themselves very busy, you can go and support them by doing the nutrition counseling and then filling the tables. Sometimes the midwife do the counseling all right. Whether it is done well or not, that one is another issue. But they are even too busy to fill in the tables. But if you are a nutrition officer, and I've seen places where there are 2 or 3 nutrition officers and they don't go to help. And the midwives sometimes feel that they are very busy and this is nutrition and the nutrition officers are not coming around to help. And therefore, they also feel that, and they are so if they are not coming to do it, so it will be good to get close to your nutrition officers, and then if they don't understand, because some of them don't even understand the chart, if they don't understand, take them through it. The day you are free, go there and then support them to feel it, and I think it will help all of us.
Thank you so much, Auntie Vero. Just a few comments from the chat box as well. And Madam Pearl is saying, thank you very much, Auntie Vero. She says your presentation was very insightful. And then 2 of our attendees are asking if the registration link can be put back into the chat box. So RD Prince, kindly do that for us. Prof. Ayi, please, your hand was up. Kindly go ahead, unmute and ask your question. Thank you.
Yeah, hello. Can you hear me? Hello?
Yes, please.
Yes.
Am I heard?
Yes, we can hear you. Yes, please.
Hello?
Prof, we can hear you.
You can hear me?
Yes.
All right, thank you very much. Auntie Vero.
Hello, Prof.
Yeah, Auntie Vero, this is a very, yes, this is a very, very brilliant and timely presentation. Coming at this time when, in fact, we have challenges, a lot of challenges among our girls and our women, pregnant women and the rest. We need more such. It shouldn't just be the theoretical presentations. It must practicalize it. Now, my issue is this. There are so many complex, as you said, etiological factors responsible for anemia. If you look at it strictly, it is not just iron or the deficiency of iron that is the cause of anemia in our settings.
Yeah.
Even though we have often ascribed this to iron deficiency. Now, I firmly believe that we are not looking at the relative deficiency of iron in our settings, which is very rife. I mean, caused by infections, by inflammation, by chronic diseases, and so on. Inflammation, I mean, these are the major causes of iron. That's anemia. That's anemia of chronic infections or inflammation. That is a major form of anemia among even pregnant women, because most of them, like you already stated, have a tendency of getting infections or have some underlying infection.
Hello, Prof.
Looks like we have lost Prof.
Yes, but we are very grateful for his comments as well. Thank you so much, Prof, if you can hear me. The link has been put into the chat box, our registration link, so kindly fill it out. Madam Irene Ifi Populampo is saying that, thank you, Ma Veru, for your insightful and elaborative presentation. I agree with her. Mr. Lukman Yusuf is saying, please will the presentation slides be shared and through all means and by when? Thank you. I think we'll get back to you on that. Thank you. I haven't seen any hands up. I stand to be corrected. If your hand is up and I can't see it, kindly unmute and then ask your question. Okay. Maxwell, Mr. Maxwell, please mute yourself and ask your question.
All right. Thank you so much. Auntie Veronica, thank you so much for the very detailed presentation. I think it's been very, very educative. What I will just want to add up before I bring my question is, sometimes with regards to vegetarian mothers, when they come in with anemia, it's even more very challenging, given the fact that they don't take animal sources. So it's just to encourage other colleagues out there to watch out for such cases. When you are dealing with a vegetarian pregnant woman, I think the best way is to allow for B12 supplementation while advising on the other sources of iron. Because once they don't take the animal sources, it will be very difficult to get your B12. Then the question I would like to ask is, at what point does a nutrition officer or a dietitian allowed to recommend iron supplement or folic acid? I'm asking this because in a typical hospital setting, I mean, most of those recommendations are left into the hands of a doctor. Now, you may have people in the district or in in the remote areas who may be given such responsibilities. So what I want to know is if you have experience in such recommendations, including the doses, and you are in a, let's say in an urban center where you have doctors who are also consulting, does the law allow you as a nutrition or a dietitian to recommend such supplement? For some may fall within the, talk about the tortima, talk about the typical ones that they mostly give in the hospitals. There are some that may come from other companies that you may look at the profile, look at the researches and think that this may be of benefit. So I just want to know what is the experience of our, nutrition officers at the communities, and then to some senior members on this page, what is actually the right thing. So if a dietitian or nutritionist recommend a supplement to a patient in the hospital and there's an issue, does the law really cover you up? So that's the question I want us to if it can be addressed for me. Thank you so much.
Thank you so much. This is a very thought-provoking question. Maybe the senior nutritionists and dietitians on the call may contribute, but for me, I think as a nutritionist or as a dietitian, your work allows you to recommend supplements for people you think. So for instance, if you're a dietitian and somebody comes to you and you think the person is not eating right and he needs to be supplemented, I think you can recommend, because supplements are over-the-counter drugs. However, for a pregnant woman, I don't know what to say, because for me, I would not recommend you to give the supplement to a pregnant woman, to write supplement to a pregnant woman. For me, that is my thought on it. I don't know what the law says, and I don't know what the job description of a dietitian says, whether the dietitian is supposed to prescribe, but for my layman view, I think for a non-pregnant person who doesn't have any complications or any conditions that may be contraindicated, you may be able to suggest some over-the-counter supplements. But for a pregnant woman, I will not advise. But Prof, I can only see Prof that I know. I haven't checked the others on the call. So I can only, if Prof is still there, Prof can respond, or if any of the dietitians are there who can respond, they can also respond.
Thank you so much, Auntie Vero. Please, we would end on this thought-provoking question and thought-provoking recommendations, thought-provoking answers. Please, you can put, if you have any take on this question, please put it in the chat whilst we are waiting a feedback on it. It is really something that we'll have to go and think through and find out in terms of our job description, our practices, what can we do and when? Even if we wish to do it, is it what is accepted within our sphere of practice? On that note, I would like to thank you, Auntie Vero, so much. It has been a highly educative, highly insightful presentation. We are grateful for your time. I introduced Auntie Vero earlier, so some people came onto the call a bit late. So Auntie Vero is actually the Acting Deputy Director of Nutrition for Ghana Health Service. So we can see the high level of expertise we had today. Auntie Vero, thank you so much from all of us. We are very grateful.
I've put on my camera for those who don't know me.
Oh, that's lovely. Thank you. Thank you so much. So we thank you. Thank you for your time. I really learned so much, and I'm sure that all of us, the participants who were able to join us today, have learned so much as well. We are very
Thank
grateful.
you. Thank you so much.
Thank you. Dear audience, we are not done. GAND has something for us. Are you done? Yes, if you are on the call, he wants to a bit on the upcoming conference that we have in Masai Kumasi. So Danny, if you're on the call, kindly take over. Thank you. Please, do we have RD on the call? If not, RD Prince, can I hear from you, please?
Yeah, hello, Dede. Great job, great job. Thank you
Yes,
very much,
please.
Madam Veronica Cote. Very, 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 very insightful presentation. I've learned a lot myself. Yes, chairman of the Conference of Nutrition and Dietetics, CONT, 2023 will say, our Christmas or Eid is coming in 2 months. Please, we are going to Kumasi. All of us are going to Kumasi, and our committee has published the call for abstract. It's a conference for nutritionists, dietitians, by nutritionists and dietitians, and it's all about us. It is the time that we can see ourselves, share ideas, share our researches, clinical, public health, all the kinds of work we have done as individuals. We are going to share and have a lot of discussion. It's a congress, so we'll discuss a lot of things that benefit nutritionists and dietitians. So because
RD Prince, please, we are having a challenge hearing you.
is 2 months away. We want all of us, especially because the
RD Prince. Mr. Bedu. All right, whilst we are waiting for RD Prince to come back online, please, the link for registration has been put into the chat box. Kindly fill it out so that we would have proof in quotes that you attended today's session. So please go to the chat box and then press on the link, and then it will send you to a Google page where you can put your details into the documents as per what it requires. RD Prince.
hello, sorry,
Okay.
sorry, my network dropped. Yes, so I think I was saying that the call for our conference is out for abstract. The call for abstract is out. Any research you have done as departments in the various hospitals, in the communities, in the various academic academic structures, and also let's budget for the coming conference. It's in Kumasi, and everything has been put in place to make it a memorable one. This is going to be our second biennial congress, and please let's do our best to all arrange and be part of it. And I think it will be a feather in the cap of our great organization, GAND. Thank you so very much. Let's stick to our pages. More information will be published there. And if you have any concerns, please, you can ask any of the GAND governing board members, or you can put your concerns on our WhatsApp page, our Telegram page, or contact the governing board members individually as and when you can have opportunity. Thank you so much, Dede. Over.
Thank you so much, Prince. Thank you. So we are ready for
Myself on
the
this call.
conference. Thank you. Someone asked how he or she will join the association. Please kindly contact RD Prince for more information on that. Okay, so dear participants, we've come to the end of today's program. And once again, we are very grateful to our presenter for sending us through a very insightful presentation. We've learned so much and we are grateful to her. We thank GAN for organizing this session for us. And thanks goes to all of you for joining us to make today's program a success. I wish you a lovely evening, and then we'll meet again. Thank you and goodbye.
Thank you.